Today, I would like to introduce you to the world of monogenic familial hypercholesterolemia and the techniques used for screening for it, and some of the practical issues that come to light as you have to run lipid clinics and deliver genetic screening programs for the disorder. Familial hypercholesterolemia, as it's taught in the textbooks, is a reasonably straightforward disorder. You have a high total cholesterol, and in particular raised LDL cholesterol. You have physical signs with involved deposition of cholesterol in tendons and around the ring of the eye, and you have a strong family history of premature coronary artery disease, usually before round age in the 50s. Its causation is from 4 major genes: the LDL receptor mutation, which accounts for about 90%, a fraction of about 5% that are due to defects in the ligand, the ApoB lipoprotein that binds to the LDL receptor, some due to overactivity of a controller of LDL receptor expression, the PCSK9 gene, and then we have a few rare and types of which we have point mutations in ApoE, and we also have autosomal recessive forms of FH affecting lysosome biology. The typical pedigree, again, as taught in the textbooks, is like this, where you have a strong autosomal dominant inheritance of either hypercholesterolemia and or coronary heart disease throughout a family, and this enables you to do highly effective cascade screening, either upwards and across in the family or downwards to children. And the yield of such studies is classically supposed to be about 3.5 affected individuals per index case detected. Of course, that is heterozygous familial hypercholesterolemia. The rarer form of monogenic homozygous or compound heterozygous FH is far rarer. It's got a prevalence of about 1 in 350,000. The lipids are more severe, with a cholesterol usually above 13 millimoles. It's got a restricted geographical prevalence due to often founder effects, such as in South Africa and Quebec, and is associated with a very low life expectancy of 33 years. There are various subtypes which are managed slightly differently because, as with all homozygous conditions, there is a wide variety of presentations, but on the whole, they tend to be severe. So, what is the issue that we find ourselves with? The problem is that while heterozygous FH at a prevalence of 1 in 300 is one of the commonest autosomal disorders in man, less than 25% of cases have been identified. We know that there are other causes of premature myocardial infarction and raised cholesterol, and those involve certain loci associated premature coronary disease, changes in lipids due to other biological processes, and also the effects of diets and alcohol. We also have the problem that there is substantial overlap with the normal population. In the UK, about 12% of the UK population have a family history of coronary heart disease in a first-degree relative before age 65. And 2 to 3% have that before age 65. About 2 to 15% of the UK population have a total cholesterol between over 7.5, with the prevalence being higher in the north and west of the UK than in the south and east, and it's also age dependent. And then lastly, we have the ability to identify various characteristic physical signs. The standard methods used to try and identify individuals with FH for index case testing are a variety of clinical scores and clinical criteria. Originally, we used to use the Simon-Broom criteria, which basically rely on LDL cholesterol, which in the UK terms is above the 90th centile, and allied with the presence of physical signs or DNA evidence of mutation or premature coronary disease in the family. That is increasingly being superseded by the use of a quantitative score, which actually gives a more probability-based estimate of whether one should actually gene test an individual or not. And these are the Dutch or European score criteria, with the highest priority being given to patients with DNA mutations, those with physical signs, and thereafter high cholesterol or instances found in family histories. And there, definite familial hyperglycemia is considered a score over 8 points, and most clinics would use a cutoff of 6 as being acceptable cutoff to actually justify screening, with a probability of finding a case of somewhere in the region of 30 to 50%. So we have used those kind of criteria to set up a variety of population-based screening projects, and these are well established in the Netherlands, in Norway, and in Slovenia. We have countries where we have a little bit more variable testing, such that there are population programs in Wales and Scotland, for instance, but England has a highly regional program. And similarly in Spain, there is variation between the different regions as to how much FH screening is done based on regional priorities. So what are the clinical signs of FH? These are the tendon xanthometer. These are the lumps in the tendons found on the knuckles, or the thickened Achilles tendon, sometimes associated with inflammation and tendinitis. In the most severe form, you actually have lipid deposition over the cholesterol in the tendons, and then you get these tuberous xanthometeras in the lower left panel, which are more typical of homozygous familial hypercholesterolemia. Why are tendon xanthometer used as a surrogate for prioritizing people for screening? It is their very strong relationship with cardiovascular risk, such that in any age group, tendon xanthometer will have a strong association with risk and will probably give you a excess risk of about 2 to 3-fold, depending on the study. How did tendon xanthometer occur? They're usually a function of a degree of cholesterol elevation and time of exposure. So they tend to be far more prevalent in older screened populations than in younger screened populations. And as we increasingly move to younger age at screening, this is becoming more of an issue. And this can be illustrated by this slide, which is actually very, very difficult to assemble because finding age-related prevalence data in FH is difficult. No one seems to record it. So we do have an increasing prevalence of both tendon xanthometer, you can see peaking around about age 50, arcus around the cholesterol deposition around the eye, sort of basically continuously increase across age, and xanthelasma, which are eyelid lumps of collated cholesterol, which have a moderate degree of specificity, far less prevalent. But where we have got surveys of looking at prevalence data for 2 years at different times, there does actually seem to be a slight reduction in the prevalence of tendon xanthometer with the years. Now, is that ascertainment bias or is it a change in biology? No one really knows. The other mechanism for seeing whether you can quickly identify patients with familial hyperglycemia is to target those with the highest cholesterols. The idea being that there is a bimodal distribution and that FH tend to be higher than the general population, and therefore if you set your cutoff high enough, you'll get a high degree of specificity. And the general cutoff seems to be around 9 millimoles per litre, and that's been accepted in a number of guidelines and has actually also had some degree of validation. The problem, again, is that the real world is not quite so simple. Much of the data that we have around familial hyperglycemia is historical. It's also concentrated in those that were referred, and those were those ones with the most severe histories and the highest cholesterols. And this can be illustrated by some of the cohort data, just cross-mapping them onto the known population distributions. Secondly, we do seem to be finding that there is a falling prevalence of physical signs. The best data is in South Africa, where it's been gathered routinely over the last 20 years, and you can see that there does seem to be somewhat of a reduction in prevalence over the years. Now, given those kind of issues, the next idea has been, well, let's use large-scale databases to try and identify cases more systematically using the totality of the available data. And there are various computer-based electronic healthcare screening strategies out there, of which probably the best known is FAMCAT, which was devised in the UK, and that uses a lot of the principles we've already heard of: the highest cholesterol ever, age, gender, a negative modifier for triglycerides, drug therapies as a surrogate to allow you to back calculate, family histories. And there's a similar scoring system was derived from the Dutch database, which looks very similar, but actually uses a quite complicated algorithm to calculate a percentage risk. There is very little data on how these algorithms perform in practice, but none of them seem to deliver the area under curve that they, in reality, that they have delivered in initial screening data, where AUCs are typically quoted around the 0.85 to 0.9 region, but actually, in reality, it seems to be closer to about 60%, mostly because the populations that are used to derive these are a lot cleaner in terms of data and more comprehensive in forms of data than the reality when you look at electronic healthcare records. So if it's too difficult to actually screen for FH in adults, can we do it the other way around? Can we use children who have less discordant diets, less age-related effects to identify individuals with FH? And it's been known that in children, we get divergence in carotid scans and intermediate thicknesses and measures of atherosclerosis from around virtually birth. They become significant at around age 6, and you can actually, and treatment will potentially normalize them if you start it early enough. This has led to the idea that also there is less variation in pediatric populations, has led to the idea that if you screen children, because there is less competing and confounding, you can then use the principles of cascade screening to identify adults. And this has actually been done, and this was done by David Wald in the UK, and he showed that you can use multiples of the median for cholesterol to identify potential cases of FH, who you then go and genotype, and this gives you quite a high degree of specificity, and then thereafter that you can find populations of affected parents and unaffected parents and separate them quite effectively. This was an initial pilot study, and this is now going to be attempted to be reproduced on a far larger scale to see whether it works in reality on 40,000 unselected individuals in the UK. So that brings us back to the core problem. What is FH? So it is a disease characterized by early ischemic heart disease, high LDL cholesterol, physical signs, and a number of other things. So in close relatives, you have to have an ascertained history of ischemic heart disease. And if you're going to use cholesterol screening in families, you have to ask the relatives to name the number. There are too many people who, if questioned, will say, oh yes, my relative had coronary disease and had elevated cholesterol because they were put on a treatment. If you're looking at FH screening, you need to know the number. The problem that we have is that what is not FH can all look remarkably like it. You can have a high cholesterol alone by not FH causes. And as the prevalence of coronary disease in the general population is falling due to lifestyle factors, more and more FH is presenting just with hypercholesterolemia. We have central obesity with the metabolic syndrome. That is tending to raise triglycerides. And as I mentioned, some of these scoring systems give you a negative bias for high triglycerides. We have non-high carbohydrate diets. These lead to fatty liver. Fatty liver leads to excess cholesterol production. And if you're reasonably fit and not too overweight, the triglycerides will be cleared, but the hypercholesteremia will remain. And about 30% of lipid clinic work these days is actually non-alcoholic fatty liver disease. And they're often distinguished by a borderline raised transaminases, but that's a very non-specific and insensitive sign, being found in about only 30% of cases. And lastly, we have confounding from the menopause in women, where some women go into the menopause with relatively average cholesterol levels, but come out with levels that are above the 75th centile. So adding 2 millimoles per litre is not unheard of. So what about the confounders that are relevant? Well, one of these is a pseudo-autosomal dominant condition called familial combined hyperlipidemia of similar frequency. It's got a phenotype which is classically supposed to have raised triglycerides, but again, unless you're obese, unless you're insulin resistant, unless you're older, this phenotype may not show through. So it's got an environmentally determined penetrance. It's pseudodominant. There's a major role for a chromosome block of genes, of lipid genes on chromosome 11, a haploblock which has been identified, and different populations segregate to different areas of this, such that the Turkish population segregates to the Q end, and the Dutch population segregates towards the P end of chromosome 11 in large-scale mapping studies. What it is actually caused by is something else. It is a disease of leaking adipocytes. So what happens is that cholesterol and triglyceride are supposed to be secreted by the liver and then taken up by peripheral tissues, which then retain them until they're needed. But if the cells leak, and particularly if the adipose tissues leak, then you'll have excess cholesterol and fatty acids traveling to the liver. Fatty acids will be made into cholesterol by the liver, and that will give you an excess hypercholesterolemia. And this adipopathy is the likely cause of FCHL. Unfortunately, it's due to control, to the extent that we know much about it, it's due to controlling RNAs, and we don't have a good test for it. So it is a diagnosis of exclusion. The other confounder that we have is in the context of premature coronary disease. When you look at acute coronary syndrome populations with high cholesterols, these are over a 4.5 millimole cutoff, you'll find that only about 2 or 3% of them are actually due to monogenic familial hypercholesterolemia. About 6 or 7% of them are actually due to other lipid causes, of which the commonest is raised lipoprotein A. Lipoprotein A is genetically inherited. It is essentially an LDL particle with an added additional protein. The levels of that protein are determined by the numbers of the repeats that are present in it. Small numbers of repeats equals high plasma level. High number of repeats equals low plasma level. Because in European populations, the commonest form is that most individuals have a high copy number. The commonest is a null. So a null times a present with someone with a short allele, and that short repeat number gives you a high LPA and can translate, because this is genetically inherited, to an autosomal dominant pattern of inheritance. This is a lot more complicated in West African populations and African populations in general, where the distribution is far more normal and actually you have additive effects. And what we clearly see with LPA is that as the levels go up, there's an increasing association with cardiovascular risk, so that the risk levels approximately double to treble when you get to the highest quintiles. The average excess risk for familial hypercholesterolemia is somewhere between 2 and 3. And so you can see this gives you a very good phenocopy in epidemiological terms for high risk of premature coronary disease. LPA is not easy to capture through genetic sequencing. There have been attempts to look at sequencing it and come up with genetic SNP scores that will predict LPA levels, but the large haploblocks of 131 amino acids that determine the repeats, you would need very large deep sequencing to actually, and quite sophisticated computing to be able to determine at the moment. It's just cheaper to do an ordinary test and measure the protein level. The other way of looking at things, which is becoming very popular, is polygenic risk scores. And we can do genome-wide scores, we can do restricted scores, and you can look at the numbers of, let's say, 12 variants, 30 variants, or up to 6 million SNPs if you want. And all those studies tend to show the same kind of story, that up to about the 75th centile, you have a somewhat reasonably straightforward straight line incidence, excess incidence and risk. And then over the 75th centile, the risk rapidly escalates, so that such that by the 90th centile, you have a very high prevalence of coronary disease. And there has been the idea that we can use these SNP scores based on whichever SNP panel we want to define who the cases that are monogenic FH and those that are most likely to have polygenic FH, but maybe of similar clinical severity. There have been lots of case series that are showing that the most extreme ends of the polygenic SNP distribution above the 90th centile have equivalent risks to those with monogenic disease. So that's the theory. What happens if you try and do it in practice? Now, we've had a number of attempts of doing it from our rather large lipid service in London, and we've looked at various methods of classification. And that is where we have come up with some simple principles, that you have to identify risks and you have to retake histories. Histories as provided by primary care, unfortunately, are not detailed enough and don't give you what you need to do an accurate risk scoring about 2/3 of the time. You then have to question patients about what their cholesterol levels are and what their relatives' cholesterol levels are. If they don't know the number, actually, it's not helpful. You can't use the risk scoring systems like the Dutch scoring system to get any useful information. And we can do all these kinds of classification, and you can see that personal family histories of premature coronary disease are a very strong predictor. So are defined family histories with relatives with premature disease, because that tends to be a well-known fact in families. And if you can get very high LDLs, that works very, very nicely from a family history. But if it's just slightly high, then it's not quite so good. The alternative way of doing this is, let's forget about the family history. Let's forget about that kind of work. This is all too subjective. Let's go and get some hard evidence. One of the ways of doing this is by imaging, and you can measure approximately the atheroma burden in large arteries, and we often use the carotids to do this. And you can do it by the intima media thickness, which is a moderately good measure, or better if patients have refined stenosis or plaque. If you look at FH monogenic FH patients compared to controls in the same families, unaffected relatives, you can see there's a reasonably good separation from early ages at about the 75th centile, though it's not perfect. How quantitatively good is this? Well, it's difficult to determine. Our best guess is that it gives you about a 4-fold better prediction rate if you use imaging. Family histories give you about a 2.5 to 3-fold better prediction rate. And we can use this kind of technique in people that are treated, and monogenic that are treated still tend to have higher cholesterols and IMTs than they would if they're than polygenic cases. And so that means that this technique has some validity in prior treated populations, which is what often we tend to get when we do health record screening. And the data for coronary calcium scores is similar, but not as well defined. So have we got data on mutation screening? Well, the best data is from Holland, where they have screened millions of people. And one of the things from it that comes out is that the bimodal distributions are present, but the bimodal distributions overlap considerably more than you might find convenient. Thus, for instance, we can find cases of monogenic familial hypercholesterolemia with LDL cholesterols as low as 2 millimoles per liter, which is the acceptable treatment target for someone with polygenic disease with established cardiovascular disease. Not very many, but enough. And it's a little bit easier if you segregate out the familial defective ApoB gene, because that's the mildest of the groups. You shift it up slightly, and the distribution shifts up if you look at LDLR mutations alone. This always begs the question, what do we do about it? Because if someone has a low LDL cholesterol and is gene positive, monogenic disease, should we treat them? All the guidelines say as soon as you get a monogenic diagnosis, treat. But if they don't show any progression because their phenotype does not show a high LDL, then are we just over-treating and causing the risk of side effects? And there is some data to suggest that. And this is data from a Dutch group showing exactly that we don't see a difference. Or should we be a bit more subtle? Should we actually start risk scoring people with familial hypercholesterolemia like we risk score in general cardiovascular disease? And there are methods to do it. The Safe Heart Score and Montreal Heart FH score do this. It's mostly driven by age and smoking as the principal, and to a lesser extent by achieved LDL. Now, these have been shown in theoretical studies to be useful, but we don't know whether they're actually practically useful or whether we should stratify treatment and monogenic treatment on that basis. So is it cost effective? Well, there have been a number of studies done, and the health economics of screening for FH is always positive. It's about somewhere between 4,000 and 9,000 pounds to euros per life year saved. If you actually look at payback times in terms of events avoided, so this is a budget impact model, you can see that we get payback on a universal screening policy sometime after 4 years. The question then is we've done all these studies against our current benchmark, which is placebo, but many countries are now introducing general population screening for cardiovascular disease starting at around age 50, and only a minority these days of FH cases have coronary disease before age 50. We really don't know what the health economics of screening is in models where we have universal population CVD risk testing. And lastly, we know less than we think. If we look historically, like with coronary disease, there was a peak in coronary disease in the 1960s and 70s. And with FH, the peak was higher, as we'd expect, but it started to drop probably in the early 80s and has accelerated down in the 90s. The general population, there is a divergence, and that is the excess effect of obesity and diabetes. That is a data on the left that I extrapolated from a number of studies, but just to show that it is actually probably real, Richard Peto has actually done analysis for vascular mortality and shown that in the general population, the kind of trend curves that we're seeing are actually probably real. So the evidence for excess treatment and excess risk is becoming weaker for reasons we don't quite understand, but it may actually relate to smoking, it may relate to particulate air pollution, no one really knows. So in summary, we know that FH is an autosomal disorder with a well-defined phenotype that should be easy to screen for. In reality, we have problems with phenocopies, some of which actually do require treatment identification, such as familial combined hyperlipidemia, those likely with high lipoproteinase, those with polygenic risk scores above the 90th centile, those with other causes of high cholesterol, because many of those manifest as premature coronary disease in the underlying, related to the underlying condition. We know that progression varies. We might have to individualize our approach a lot more, and that's where the role of imaging comes in. And lastly, should we stop looking at FH as just a simple one club strategy? No one goes out on the golf course with a driver only. Everyone goes out with a bag of clubs. The same approach applies in cardiovascular disease. We screen for general cardiovascular disease with multifactorial elements and risk scores. Maybe we should do the same for FH. Thank you very much.